We have today our speaker, Dr. Riederer. She's a child and adolescent psychiatrist for the Division of Mental Health and Child Development at UCSF Benioff Children's Hospital, Oakland, and in the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. So she practices in the outpatient clinic at Benioff Children's Hospital, Oakland, and also as part of the consultation liaison service at the Benioff Children's Hospitals in San Francisco and Oakland. And she also serves as our Associate Director for Community Engagement here at CAP, and she'll be speaking today on depression.
Okay. Thank you so much, Joanne, and I'm sorry about your technical problems. It always happens to me too. I am so happy to be here today for our Project Echo to talk with you all about depression. It's nice to see so many familiar faces and names of, folks I've been able to talk with on the phone. And so I will plan to just speak for about 10 minutes briefly on a quick overview of depression. My goal is to cover, how depression presents clinically in children and teens and how that is different from adults, how to screen for and assess depression, and how to really triage kind of the severity of depression and then appropriate treatment, which I will review briefly. Today, we will not be discussing in my presentation SSRIs in detail because that's a different SSRI. There's a different CAP Echo that will specifically focus on SSRIs, but of course I will discuss that briefly and then we can have some time hopefully for a Q&A before we jump into the case. Next slide, please. And I have no disclosures. So what is depression? We, think of depression in a lot of different ways. And I will talk about the DSM-5 criteria for depression, but generally we think about, a significantly low mood that manifests over, at least a 2-week period of time. So not just for one day or several hours. That's often accompanied by a lack of interest to do things. And, the clinical term for that is anhedonia. And additionally, a variety of other sort of neurovegetative and psychological symptoms, sometimes accompanied by, thoughts about not wanting to be alive anymore or wishing to be dead. There's a ton of literature on depression in the adult world. As over the last couple of decades, there's been a lot more focus on pediatric depression. And, our main focus in CAP has been on the increasing prevalence of, pediatric mental health disorders, depression being a primary one of those, and really kind of seeing an increase in teen depression. There is a lot of, different statistics from different studies on the prevalence of depression, but I think right now estimates are that over 50% or over 60% of young people by the age of 16 will have experienced depression. One thing to note is that depression can present really differently in children and adolescents compared to adults. And so they may not present with sort of the typical symptoms we think of as sort of like really depressed mood, crying, lethargy, that type of thing. In children, we might see more irritability, somatic complaints, expressions of boredom, manifestations such as separation anxiety, behavioral problems, so more externalizing manifestations, and even hallucinations. And then similarly in adolescence, we often see irritability. We could see behavioral problems. Adolescents may report sadness or change in mood. They might report sort of the neurovegetative symptoms such as increased sleep or appetite. There could be suicidal ideation, boredom as well, and symptoms related to sort of the menstrual cycle. So I think the overall takeaway is that even if the patient, a child or teen, is not reporting sadness per se, even if they're manifesting irritability, you want to have depression on your radar and as part of your differential. And that sometimes, the experience of depression can be really different depending on who your reporter is. So if you're talking with the parents or teachers or guardians or other people taking care of the teen, they might be seeing more externalizing symptoms like irritability, anger, moodiness, or other behavior changes, while the child or teen might be reporting sort of the internalizing symptoms that we tend to associate with depression. So things like sadness or poor concentration, hopelessness, suicidal ideation, sleep change. Next slide, please. So screening for depression is really important because sometimes this doesn't necessarily come up organically. There's a lot of, there can be a lot of stigma associated with mental health disorders. And as I just mentioned, depression doesn't always present in sort of the bread and butter way of low mood and, sadness. And so the AEP, as well as the American Academy of Child and Adolescent Psychiatry, recommends routine screening for depression, which I understand many practices, the majority of you are already doing kind of as, routine for teens over the age of 12. The PHQ-9 is robust, validated, and has been, kind of implemented across the United States as the mechanism for routine screening for depression. And it's relatively easy to use both for teens as well as for kind of understanding the scoring. You tally up all the questions. And then depending on the score that the child gets, 5 to 9 is considered mild depression. Under 5 would be sort of, nothing. 10 to 14 moderate depression, and 15 to 27 being severe depression, and particularly a score over 20 as being, very concerning severe depression. And you're also looking at, one of the last questions, which is about suicidal ideation. Next slide, please. So after you've done the screening for depression, that sort of leads you to the question of, how do you talk with a patient? How do you get more information? How do you do your assessment for depression? And I'll talk a little bit about sort of some clinical tips for, interviewing and using the DSM-5 criteria for depression. But I also wanted to stress that you're already doing a lot of data gathering from the other parts of your interview that can be helpful for when you're trying to assess for depression. So for example, in your HEADS assessment, you're assessing for psychosocial functioning. That is really helpful in determining kind of how the teen is impacted in their day-to-day. You're asking about, how things are going at school, with their friends, with their family. That gives you a clue into, how severe or how debilitating their symptoms are. You're maybe already doing ACEs screening, so thinking about their both chronic stress, acute stress, and history of trauma, and how that might be, impacting their mood and their functioning. And then finally, you can be asking about the DSM-5 criteria for depression, which I'll talk about in the next slide. When you do have this conversation, I know this isn't always possible, and there's often like a time limit in terms of, trying to get all this information, but it can be really helpful if you're able to interview the patient and parent separately, and especially for teens, giving them that opportunity to discuss with you what's going on, and telling them, very sort of clearly that what they tell you is confidential, unless there is a concern about safety, for example, suicidality. That's when, you would have to report that to their parents or, make a plan, but otherwise what they share with you is confidential. It's also just really important to ask, and maybe you can use if you've done the PHQ-9 screening, you can use that as a launching board, saying things like, hey, I noticed, you mentioned that you're experiencing this and this and this, every day of the week or several times a week. Tell me about that, like what's going on with you. So kind of, if you have the PHQ-9 already in your hands, and using that as an opportunity to just ask more and inquire and be curious about what's going on with the patient. As I mentioned before, sometimes there is stigma about mental health conditions. And so using normalizing statements like, it's really common for teens to struggle with sadness or low mood, or it sounds like there's so much stress going on for you. I would imagine, or other teens who deal with stress like this, they feel really overwhelmed. How does it feel for you? Just so that you're, coming at it with from a place of, concern at the same time, but also that you're not surprised or shocked that they may be feeling this way. And then it's always nice. I know it can't always be possible, but if you're able to get information from other people, such as parents, teachers, therapists, that can also be extremely helpful in both diagnosing depression and then sort of like monitoring how things are going in your follow-up visits. I think there's been studies of teen depression where they found really, really different reportings of a patient's mood depending on who you ask. So I think they were, doing a trial of Prozac, and then if they just asked the patient, there was no effect from the Prozac, but if they asked the family, there was like a statistically significant and clinically significant improvement from Prozac. So I think it really just underscores that sort of an assessment from depression, ideally is not just from one source. Next slide, please. So the DSM-5 criteria for depression, this is what psychiatrists and other clinicians use to determine whether or not somebody meets criteria for a major depressive disorder, and involves, maybe you remember this mnemonic from your training, but it's SIG-ECAP. So we're thinking about at least the presence of either depressed mood or loss of interest or pleasure or irritability in teens and children for over a 2-week period, plus at least 5 of the SIG-ECAP's symptoms. So that includes, either sleep changes, either increased or decreased, loss of interest in activities that usually interest them, feelings of guilt or worthlessness, low energy or fatigue, problems with concentration, that might include like difficulty focusing in schoolwork or just having trouble making decisions. Changes in appetite, usually it's declined, but sometimes it can be increased appetite, as well as psychomotor, either agitation, so feeling really restless, or feeling really slow and lethargic. And then, of course, the piece about safety, if there's any suicidal ideation, plan, or attempt. And when thinking about all of these different categories of symptoms of depression, I always want to think about how these symptoms are in different dimensions. One is, are they mild to severe? Is it severe sleep change, appetite, concentration, etc., or are the changes mild? Next, I want to think about how much distress is the child in. Are the symptoms causing a lot of distress or just minimal distress? And then most importantly, this is really crucial for, psychiatry and pediatric psychiatry, is we always want to be thinking about functional impairment. How are the symptoms impacting the child? And we think about functional impairment in 3 domains: at home, with peers, and at school. So, are these symptoms getting in the way of the child doing okay at school, having friendships, or, getting along with family members? Those I think are always really crucial, like nice ways to assess how the symptoms that you're seeing in the clinic, or that the patient and the parents are reporting, how is that really impacting the child? And thinking about all these factors can help you, along with the PHQ-9 and kind of the score that the patient gets on the PHQ-9, think about how severe the depression is. Is it mild, moderate, or severe? And then that can inform sort of your recommendations and what the plan is. Next slide, please. I just want to, make a note that when you are, doing your evaluation for depression, it's also good to keep in mind that there can be, other both psychiatric and medical conditions that can sort of mask as depression, and that depression is very commonly comorbid with other mental health disorders such as anxiety, ADHD, and behavior disorders, trauma, as well as, substance use. There's some other things on this list, for example, bipolar disorder and psychosis, which are very, very rare. But, again, if there are other red flags that make you think this seems like depression, plus there's something odd or there's something else going on, to think about that further. And also that, there can be some medical conditions that sort of manifest as depression, such as hypothyroidism, anemia, certain cancers, autoimmune disease, PMDD, or chronic fatigue, as well as medications that can potentially, impact one's mood, such as using steroids, some OCPs, as well as, sort of the effect of the environment. So whether there's, certain stressors going on for the patient or loss of a loved one, those types of, events can also significantly impact one's mood. Next slide, please. So this is in the Project Echo handout. So I know it's a little bit small on the screen, and hopefully you won't have to squint when you can actually see it in your handout. But this sort of goes over, sort of a basic algorithm for thinking about depression and, how to tailor treatment depending on whether it's mild depression, moderate depression, or severe depression. So, it starts with, if you have a concern for depression, you're gathering the signs and symptoms of depression, you're doing sort of a PHQ-9, or there's also the short mood and feelings questionnaire, which you can do for younger kids under the age of 12. You're thinking about trauma and doing a safety check, whether or not the patient's having suicidal ideation. And then you're going over the DSM-5 criteria, whether or not they have all the other symptoms associated with depression. Once you're kind of doing that evaluation, then you're categorizing the patient's depression into either no depression, mild, moderate, or severe. In the case of mild depression, the AAP and ACAP general guidelines are that you can do some psychoeducation about mood disorders, some support, and then just routine and active monitoring, and have them follow up in a couple of weeks, track their rating scales, make sure that they're safe and that symptoms haven't progress significantly. Otherwise, in moderate or severe depression, the algorithm suggests that you also do that similar psychoeducation support and monitoring, where you're tracking rating scales, having them follow up regularly and assessing safety. And in addition, you're recommending psychotherapy and potentially medication. So psychotherapy for both moderate and severe depression, and then considering SSRI treatment in the moderate category, and most likely or definitely suggesting SSRI treatment if it's severe depression. And again, that's if the PHQ-9 score is over 14, and based on your assessment of all the other factors, such as the severity of symptoms, the level of distress, and the functional impairment, if all of that is really significant. And then I just wanted to add a note, when you're getting into the severe category of depression, then you might want to think about a referral to psychiatry. Other situations where we think, referral to psychiatry would be really appropriate is if there are definitely some safety concerns, or the patient has been hospitalized, if there's other psychiatric comorbidities making the situation a complex, complex case, if there's psychosis, for example, as a comorbidity, if there's, if the mood disorder is interfering with medical treatment, so if they have some comorbid medical conditions and they're not taking care of themselves. And then if you have tried them on treatment, so that's again psychotherapy or SSRI treatment, and there's no response after 8 weeks, or they are on multiple medications, then definitely refer to psychiatry. Okay, next slide, please. So again, the psychoeducation support and monitoring is something that ideally you're providing to all patients who are having either mild, moderate, or severe depression. And that can be the psychoeducation piece, talking about, the cause of depression, how the mind and body are connected, and just kind of overall how to take care of the body as a way of taking care of the mind. So that includes things like talking about getting enough sleep, getting, good nutrition, getting regular exercise, self-care, and some, sort of basics of like maybe keeping a journal and journaling positive events, tracking mood changes, encouraging behavioral activation. That means kind of getting a sense of like, what are the activities that you enjoy? Can you go out into the world instead of isolating at home, kind of on your phone, that type of thing. And then, some kids and teens really like these like relaxation strategies. Some aren't a huge fan, but you could, give some education on just like ways to pause throughout the day and do some relaxation strategies, or have them check out, there's just unlimited numbers of mindful apps that they can find on their phones now. But I think, some common ones that I've seen and have heard are great are Headspace and Calm, for example. as just ways for kids to kind of practice relaxation strategies and mindfulness, which can also, help with mood and anxiety. Next slide, please. And then the psychotherapy piece. So the evidence-based psychotherapy for depression and anxiety is called cognitive behavioral therapy, or CBT. The premise is that our thoughts, feelings, and actions are all interconnected. And so, when there is a disturbance in, for example, our feelings, we can alter that by changing our actions and changing our thoughts, and vice versa. Everything is connected. So we can change our thoughts by changing our feelings and our actions. And there's a lot of it's a very active type of therapy where, the therapist is working with patients on, practicing skills and kind of figuring out in specific situations what those thoughts and behaviors are that are kind of influencing their skills or their feelings. I will say that, I've heard this a lot. It's hard to find a therapist who is like, yes, I do CBT. There's so many therapists out there, and sometimes, families aren't able to find just like somebody who does CBT. They might be kind of like a general therapist. And, I think it's been my experience that, it seems like CBT is the best, but therapy is better than no therapy. And I think a lot of therapists do, in their training, get some basis in CBT and maybe incorporate that into what they're doing. So, generally, I recommend that the families try to find a CBT therapist, but just being realistic, if that's not available, then, therapy is helpful. And in over the years in, various studies in pediatric depression, CBT has been like the gold standard, but they have looked at other types of therapy. For example, interpersonal therapy has been found to be effective, as well as, brief, like short-term psychodynamic psychotherapy. So that's more of you're thinking like Freud sitting on the couch type of therapy. And even that has been shown to be helpful in some other smaller studies. So I think that's all to say that we shouldn't dismiss other therapies as it's not going to work, even though CBT is the gold standard and ideally everybody with depression would be getting it. Next slide, please. And then I just kind of want to say a quick word about SSRIs. So, treatment for pediatric depression is with SSRIs, and Prozac and Lexapro are FDA approved for depression. Prozac for kids over 8, Lexapro for kids over 12. Sertraline is not FDA approved for depression in the pediatric population, but it is approved for OCD, which means that it is safe to use in the pediatric population, and it is approved for adults with depression. I think part of the reason it's not FDA approved for depression in the pediatric population is just because there hasn't been, the robust trial where they've been angling for FDA approval. So all of that is to say that I think all 3 options are great. In most of the literature, if you look at really like the NICE guidelines or AAP guidelines, everybody says to start with Prozac, so you can certainly follow that rule. I think the main thing is that, with most SSRIs, the things to remember are that they don't work immediately. It takes a couple of weeks, generally well tolerated, really safe. You might need to titrate up to get to the right dose. So it could be a couple of weeks titration. After 4 weeks, generally, we want to increase the dose. You want to have somebody on a recommended, kind of a minimally recommended dose for at least 8 weeks. So for example, for Prozac, that's 20 milligrams. For Lexapro, that's 10 milligrams. For sertraline, that can be somewhere between 50 to 100 milligrams in order to consider it a full adequate trial. Next slide, please. And then we have a lot of other resources on our website, but, I think there's a lot of books out there that can support kids and teens with, dealing with depression, suicidal ideation, non-suicidal self-injury, or anxiety. And so that's sort of a plug to check out our website for some of the resources for families. And again, to use our CAP phone consultation. If you are dealing with, if you're treating a patient where you're concerned about depression, they're having trouble either accessing therapy or resources, or you want to get a second opinion about like what else to do, we could potentially, facilitate a ROC consult, which is a one-time meeting with one of our psychologists to help kind of figure out what's going on and what needs to happen. We can give recommendations about medications, and we can give recommendations about other resources for the family.